Hello, I'm Jeanne E Poole. I'm the editor-in-chief of the HRO2 Journal, and welcome to the November 2024 podcast. We start off with a paper titled Cost Savings Associated with Extended Battery Longevity in Cardiac Resynchronization Therapy Defibrillators by Dr. Jeffrey Williams and colleagues. The background to this study is that CRT-D are devices established as treatment for symptomatic heart failure patients at risk for sudden cardiac death. Battery depletion, however, poses a significant clinical and economic burden. Extended life service could reduce costs. The objective of this study was to estimate the cost savings associated with extended battery longevity in Medicare patients receiving CRT-D devices. The authors evaluated using a decision tree that was used to explore three battery capacities: 1 ampere hour, 1.6 ampere hour, and 2.1 ampere hour. The outcome measures were yearly risk of all-cause mortality, device-related complications, and end of battery life. Over 6 years, the estimated costs included device implantation, replacement, follow-up appointments, and complications. The authors find that the average total cost to Medicare over 6 years were $14,527, $48,515, and $56,647 per person for the year 2023 for the 2.1, 1.6, and 1 ampere hour respectively. The total per person replacement cost for the 1 ampere hour devices was more than 4 times that of the 2.1 ampere hour devices. In addition, when extrapolated to the total number of CRT-D implants over a 6-year period, the difference in costs between 2.1 ampere hour and 1.0 ampere hour battery capacity exceeded $500 million. The authors conclude that extended longevity CRT-D batteries demonstrate significant cost savings to Medicare over 6 years, and that these data indicate long-term economic considerations should be included in device selection. An editorial for this paper is provided by Dr. Matthew Bennett. The title is Cost Reduction Strategies for Cardiac Implantable Electronic Devices, Increased Battery Capacity, and Beyond. Dr. Bennett makes the point that the most significant cost savings comes from extending the interval between device implantation and generator replacement, and also with extended battery, the patient is exposed to fewer complications, but also overall lowers the cost. The next paper is Time-Dependent Improvements in Pacing Thresholds with Lumenless Leads Placed into the Right Atrium by Dr. Yasumasa Noho and colleagues. They note as a background that traditional pacemaker implantation is risky, and perforation of leads can occur when atrial leads are placed in the right atrial appendage. Recent advancements in delivery catheters have enabled atrial lead placement in the right atrial septum, potentially mitigating right atrial appendage-related complications. However, the performance of luminous leads, they note in this context, remains unclear. The objective of their study was to assess the performance of luminous leads used as atrial pacing leads. The hypothesis is that these leads might decrease the risk of perforation when compared to traditional right atrial leads placed into the right atrial appendage. The potential advantage of the lumen leads is the ability to place the lead in alternative right atrial positions. The study included 44 consecutive patients undergoing pacemaker implantation using luminous atrial leads. The lead used was the Medtronic 3830 Select Secure lead and using a C315 HIS sheath. The protocol included pacing parameters to be measured immediately after deploying the fixation screw. Parameters were then measured at 3 and 5 minutes at the end of the procedure and at every 6 months follow-up thereafter. The lead position was ideally placed into the atrial septum. The authors did not have CT scans to confirm the position in all patients, but in those that did have scans, most of them were noted to have been placed into the atrial septum. The authors found that lead parameters, including P-wave, pacing threshold, and impedance, significantly improved over time. Thresholds were all measured at 0.4 millisecond pulse width. The threshold immediately after implant was, on average, 2.0 volts at 0.4 milliseconds. At 5 minutes, it had decreased to 1.4 volts, and at the end of the procedure, the threshold was 0.95 volts, and at discharge, the threshold had decreased further to 0.78 volts. In 15 of the cases, the initial thresholds were equal to or greater than 2.5 volts, but they did decrease to less than 2 volts by the end of the procedure and continued to decrease during follow-up. The authors concluded that good thresholds could be obtained in the right atrium with luminous leads, and that the thresholds decreased over the first 5 minutes in most of the patients and continued to decrease thereafter. The next paper is titled Myeloperoxidase, an N-terminal proatrial natriuretic peptide as predictors for atrial fibrillation recurrence in patients undergoing redo ablation, by Dr. Marwan Banier and colleagues. The purpose of the study was to investigate potential biomarkers for their predictive value in patients undergoing redo ablation. The biomarkers studied included myeloperoxidase, or MPO, NT-proANP, intracellular adhesion molecule 1, and matrix metalloproteinase 2. This is a single-center prospective study of 50 consecutive patients. The patients all underwent ultra-high-density mapping. Biomarkers were determined before ablation and at 6 months of follow-up. 7-day Holters were conducted to check for AF recurrence, defined as lasting 30 seconds or more. The results showed that 11, or 22%, of the patients had recurrent AF after redo ablation. The authors looked at recurrence by Holter monitor in the 7 days post-procedure, and then again by 3 months of follow-up. Other secondary outcomes were AF burden, left atrial fibrosis as measured by high endocardial high-frequency density mapping, and LA volume. Amongst the biomarkers studied, venous MPO and NT-proANP increased over time and were predictive of early recurrence as identified on the 7-day Holter, with AUCs of 0.755 and 0.72 respectively. Matrix metalloproteinase 2 and intracellular adhesion molecule 1 and other established cardiovascular biomarkers such as NT-proB type ANP, troponin T, and C-reactive protein were not predictive of AF recurrence, although MPO and NT-proANP correlated with AF burden. The authors did identify that MPO was associated with atrial fibrosis as measured by the endocardial map, and NT-proANP was correlated with left atrial volume. The next paper is titled Local Atrial Bipolar Electrogram Voltage Drops During Cardiac Magnetic Resonance Guided Catheter Ablation of Typical Atrial Flutter, Associations with Delivered Radiofrequency Energy in Peri-Procedural Imaging, by Dr. Hedwig Nies and colleagues. The purpose of this study was to investigate local atrial bipolar electrogram voltage drops and the association with delivered RF energy and anatomical information derived from the peri-procedural CMR imaging. The authors studied 12 consecutive patients who all had CMR-guided CTI ablation procedures. They looked at the relative electrogram voltage drops for RF applications, pre- and post-ablation CMR imaging was performed, and associations of relative electrogram voltage drops with patient characteristics, delivered RF energy, and CTI anatomy were analyzed. Overall, 216 RF applications were evaluated from the 12 patients. Electrogram voltage amplitude at baseline was significantly higher in the group with the strongest relative electrogram voltage drop, p-value equal to or greater than 0.05, whereas RF ablation settings, including duration, power, and temperature, and lesion characteristics, impedance drop, slope of impedance drop, did not differ. The electrogram voltage amplitude at baseline, the right atrium volume index, and CTI line length showed the strongest association with relative electrogram voltage drop. 4 of 12 patients, or 33%, underwent a redo procedure. 2 patients showed a regional late reconnection, which could be visually identified in the T2 weighted images of the index procedure. The authors conclude that local electrogram voltage amplitude, LVEF, right atrial volume index, and CTI length are associated with a relative electrogram voltage drop during CMR-guided CTI ablation. And second, that post-ablation CMR imaging during the index procedure may help to identify areas of late reconnection. The next paper's title is Needle-Free Atrial Transeptal Access, a Safe and Reproducible Alternative for Left Atrial Catheterization, by Dr. Alex Pacheco-Boutillier. The background for this paper is that left atrial catheterization is a common procedure performed in EP labs to treat arrhythmogenic substrates in the left side of the heart. Needle transeptal puncture is the standard approach, but it is known it can lead to complications related to device design or operator technique, and that to reduce these complications, needle-free alternatives have been explored. The objective of this specific paper was to report on a multicenter retrospective study using a needle-free transeptal access approach to the left atrium. The outcome measures are safety and efficacy. This study was performed at 3 electrophysiology centers in Mexico, and the needle-free transeptal access, or NEPTA, uses only a guide wire without a needle or a sharp guide wire. The sheath with a dilator is guided into the fossa ovalis under fluoroscopic guidance, and using anterior force and clockwise torque to allow the guide wire to puncture the septum with minimal risk. The results of this study showed that 366 patients had this NEPTA technique performed. The operators used deflectable sheaths in 56.6% and non-deflectable sheaths in the remainder. Left atrial access via NEPTA was successful in 96.2% of the cases, but with a pericardial effusion rate, albeit the only complication, of 0.55%. The authors conclude that this technique was reproducible and safe, achieving successful access on the first or second attempt in 96.18% of the cases, regardless of the operator. The next paper is titled Differences in Clinical Significance of Atrial Tachyarrhythmias in Idiopathic Ventricular Fibrillation versus Brugada Syndrome, a multicenter study by Dr. Tomofumi Mizuno. The background to this study is that atrial tachyarrhythmias are the primary cause of inappropriate implantable cardioverter defibrillator therapy in patients with idiopathic ventricular fibrillation, and therefore are associated with a decreased quality of life, as well as potentially increased mortality. Nonetheless, the incidence of atrial tachyarrhythmias has not been clarified in this patient population. So the authors in this study sought to determine the incidence and clinical significance of atrial tachyarrhythmias in patients with idiopathic VF compared with those with Brugada syndrome. Patients were diagnosed with idiopathic VF or Brugada syndrome at 6 different hospitals. The patients were all referred for receiving an ICD and were enrolled between February of 1997 and July of 2020. Overall, 137 patients, 51 in the IVF group and 86 in the Brugada syndrome group were enrolled. Atrial tachyarrhythmias were detected in 43.1% of the patients in the idiopathic VF group and 19.8% in the Brugada syndrome group, p-value equal to or less than 0.006. Inappropriate ICD therapies due to atrial tachyarrhythmias were more frequently observed in the idiopathic ventricular fibrillation group than in the Brugada syndrome group. Conversely, there was no significant difference in appropriate ICD therapies between the two groups. A Cox regression analysis revealed no specific predictive factors for the development of atrial tachyarrhythmias in the idiopathic ventricular fibrillation group. The authors conclude that atrial tachyarrhythmia events were observed more frequently in patients with idiopathic VF than in those with Brugada syndrome, and that atrial tachyarrhythmias led to inappropriate ICD therapy in this patient population with idiopathic ventricular fibrillation. The authors suggest that clinicians be aware of the recurrence not only of ventricular arrhythmias, but also the possibility of the development of atrial tachyarrhythmias. The next paper's title is Temporal Changes in Device-Derived Daily Activity Related to Ventricular Arrhythmias from the Certitude Registry by Dr. Valentina Kutipia. The purpose of this study was to assess whether activity predicted ventricular arrhythmias or whether ventricular arrhythmias predicted change in patient activity. The Certitude Registry was used for this analysis, which included over 55,000 implanted devices that were active on home monitoring. Daily data on activity were captured by a 1-axis accelerometer. Temporal changes in activity during treated ventricular arrhythmias were analyzed using the first event and 7-day activity windows at baseline, pre-event, and post-event. The baseline period was defined as 31 to 38 days prior to a ventricular arrhythmia. Ventricular arrhythmias were categorized by heart rate greater than 200 beats per minute or equal to or less than 200 beats per minute, and by treatment, shock, or anti-tachycardia pacing. Differences were then assessed using the binomial proportion test and case crossover analysis. A total of 5,631 devices, of which 3,688 were ICDs, 1,943 were CRTDs, were analyzed with a cumulative follow-up duration of 18,354 years. Patients with ventricular arrhythmia events greater than 200 beats per minute who had received a shock, and that encompassed 593 patients, had a significant decline in activity post-ventricular arrhythmia with a median 8.7% reduction. However, if you considered anti-tachycardia pacing, there was no reduction in activity before ventricular arrhythmia events or before or after ventricular arrhythmia events in the group of patients with greater than 200 beat per minute ventricular arrhythmias. It was noted in the ventricular arrhythmias equal to or less than 200 beats per minute who had received a shock that those patients had reductions in activity following the event of 5.8% reduction. Case crossover analyses confirmed lower activity rates following ventricular arrhythmia events equal to or greater than 200 beats per minute who had received a shock. The authors conclude that in this certitude registry, they have shown a temporal decline in device-derived activity following ventricular arrhythmia events for events greater than 200 beats per minute, and for ventricular arrhythmia events less than 200 beats per minute treated with an ICD shock, but did not find changes in activity preceding a shock event. The title of the next paper is Ventricular Arrhythmias After Atrial Fibrillation, Electrical Cardioversion, a Multicenter Study by Dr. Oholi Tovia Brody. These authors sought to assess the incidence, timing, and clinical characteristics of patients with post-atrial fibrillation, electrical cardioversion-related ventricular arrhythmias. This is a multi-center observational retrospective study that included 13 centers, including patients with ventricular arrhythmias or sudden cardiac death within the 10 days of undergoing electrical cardioversion. The total number of electrical cardioversions performed during the collecting period was provided. Patients with pre-electrical cardioversion ventricular arrhythmias were excluded. 23 patients with ventricular arrhythmias were identified out of 11,897 AF electrocardioversions that were performed in the 13 centers over a median 2-year period, suggesting that the post-electrical cardioversion ventricular arrhythmia incidence was quite low at 0.2%. Patients' mean age was 71, and 56% were female. AF duration prior to electrical cardioversion was 71 plus and minus 54 days. Hypertension and heart failure were found in 74% of the patients. QT prolonging drugs were used in 74% of the patients. An index ventricular arrhythmia occurred 28.5 hours post-electrical cardioversion, including torsade de pointe, non-sustained polymorphic VT, and sudden cardiac death in 17, 5, and 1 of the patients, respectively. Post-electrical cardioversion heart rate was slower and QT duration longer compared with the pre-electrical cardioversion group. Ventricular arrhythmias reoccurred in 9 patients, occurring at 11 hours post the index ventricular arrhythmia. 2 patients had an arrhythmic death within 72 hours post-electrical cardioversion. The authors conclude that ventricular arrhythmias post-AF electrical cardioversion are rare and occur within 3 to 72 hours post-cardioversion and can be fatal. Their study gives a signal of caution, they suggest, favoring prolonged monitoring in a small subset of patients who have heart failure and maybe who are treated with class 3 antiarrhythmic drugs, especially when QT prolongation has been noted. Next up is a paper titled Sudden Arrhythmic Death in Patients with Syncope in Implantable Cardiac Monitor by Dr. Pilar Cabanas-Grandio. The methods of this paper are that this is an observational paper of clinical routine care for patients with a biotronic implantable cardiac monitor. This is the BioStream ICM and is an ongoing all-comers study observing the clinical course and treatment of patients with any indication for an implantable cardiac monitor. The study had local ethics committee approval at all of the participating institutions. All of the subjects received a biotronic biomonitor, and all of them have remote monitoring and remained in the study until a specific diagnosis was made or the device was explanted. The analysis was limited to patients whose indication for the device was syncope or pre-syncope. Standard ICM settings for the arrhythmia detection were a pause greater than 3 seconds, less than 40 beats per minute for bradycardia, and equal to or greater than 180 beats per minute for tachycardias. The home monitor sent a daily message, including up to 6 episodes of arrhythmias to the server. If a death occurred after the daily transmission, post-mortem device interrogation would be required to prove or disprove an arrhythmic death. Deaths were adjudicated by the study adverse event group, reporting and categorized them as non-sudden death, which included non-cardiovascular or cardiovascular non-arrhythmic, sudden cardiac death, or unclear. Sudden cardiac death was taken as all cases of either documented arrhythmia or unexpected death within 1 hour of symptom onset in the absence of an identifiable cause of death. All implantable cardiac monitor electrograms were transmitted by remote monitoring of the patients with sudden cardiac death and were screened for significant arrhythmias occurring between implant date and up to the time of death. By the data closing date, 580 patients with an indication of syncope or pre-syncope had been enrolled. The patients were 65 years of age and 45% were females. The cumulative follow-up duration was 818 patient years. Overall, there were 28 deaths, or 4.8% of the population, including 15 that were non-sudden, including 10 non-cardiovascular and 5 of terminal heart failure. 7 deaths of unclear cause, included 3 that were involved in a fall or accident in a public space, and 4 occurred at the patient's residence. And finally, there were 6 sudden cardiac deaths. Of the 7 deaths of unclear cause, no cause of death was available despite efforts to obtain a death certificate, and there were no remote monitoring transmissions or ICM memory interrogations that were available to prove or rule out arrhythmia as the cause of that event. Of the 6 sudden cardiac deaths, fatal arrhythmia was transmitted by remote monitoring in 3 of those cases. In the remaining 3 cases, there was 1 out-of-hospital cardiac arrest and 2 observed sudden cardiac deaths that unfortunately did not have any post-mortem ICM interrogation. Post-mortem remote monitoring reviews of all events since ICM implantation found a significant arrhythmia in 5 of the 6 sudden cardiac deaths prior to their deaths. Patient 1 had a 16-beat run and non-sustained VT, later dying of a documented sustained VT. Patients 2 and 3 had sinus arrests, episodes of 5 and 15 seconds with an escape rhythm, and died later during documented sinus arrest. 2 patients had episodes of third-degree AV block of 13 and 20 seconds in duration with an escape rhythm, and 1 patient had no significant arrhythmia recorded during the follow-up time. No specific rhythm data were available at the time of death for the last 3 patients that I mentioned, patients number 4, 5, and 6. In summary, in 580 patients with a history of syncope and an implanted cardiac monitor, 6 of 28 deaths, or 21%, were considered to be sudden cardiac deaths. 3 of the 6 sudden cardiac deaths had an arrhythmia recorded at the time of death, and in 5 of the 6 cases, a warning arrhythmia had been observed that might have justified the implantation of a pacemaker or implantable cardioverter defibrillator. The next paper is by first author Dr. Naoya Katoka and is titled Unexpected Implantation of Cardiac Resynchronization Therapy, Its Characteristics and Prognosis. The study investigated real-world data on the timing of CRT implantation, whether it was, quote, unexpected or elective, and its associated clinical characteristics by comparing the safety and efficacy of the unexpected versus elective implantations. The authors studied consecutive patients undergoing CRT implantation between March of 2010 and March of 2024, and the patients were classified into 3 groups based upon the reasons for getting the CRT. The unexpected group were patients who had sudden AV conduction disorders and systolic heart failure. The hemodynamically unexpected group were patients requiring CRT implantation during hospitalization due to worsening heart failure or cardiogenic shock and received the CRT during that hospitalization. And the third group was the elective group and comprised patients who were undergoing a planned outpatient implantation. 3 outcome measures were compared amongst the groups. 1, the safety of unplanned implantations indicated by complication rates and procedure duration. 2, the echocardiographic response to CRT at 6 months post-implantation categorized as worsened, unchanged, or improved. And 3, the clinical events following CRT, including all-cause death, durable left ventricular assist device implantation, and hospitalization for worsening heart failure. A total of 131 subjects were included in the analysis and categorized into the 3 groups. During a median follow-up of 2 years after CRT implantation, 33 subjects experienced a composite of the adverse events. At 1 year post-implantation, the electrophysiologically unexpected group had outcomes comparable to the hemodynamically unexpected group, but worse than the elective group. After 1 year, no adverse events occurred in the electrophysiologically unexpected group, and their composite event-free outcomes became comparable to those in the elective group. In contrast, the hemodynamically unexpected group experienced progressively worse outcomes over time. The authors summarized their results as first, the clinical safety and implications of unexpected or urgent cardiac CRT implantation remain inadequately understood. The safety of unexpected CRT implantation in hemodynamically unstable situations was comparable to that to the elective procedures. However, given the high incidence of adverse events in the hemodynamically unstable patients, the authors cautioned that physicians should carefully evaluate the optimal timing for CRT implantation throughout the course of heart failure management. The next paper is in our category of allied health professionals. I'm very excited about this paper. The title is Innovative Training Program for Advanced Practice Providers in Electrophysiology by Angela Sirperfal. The key findings are that the Stanford Healthcare Electrophysiology Advanced Practice Provider Fellowship is the first in the country to provide in-depth education and training for novice APPs to deliver high-level care to patients with cardiac arrhythmias. The EP-APP Fellowship Training Program has proven to be successful in transitioning novice APPs to independent practitioners within the specialty since its inception in 2021. The fellowship program in EP was found to be a feasible strategy for recruitment and training, and with a current retention rate of 100% for those hired after graduating from the EP-APP Fellowship. So I just refer the readers to the details of this program at Stanford. It's very impressive and hopefully can be modeled in other programs across the country. The next paper is a case report. The title is Type 1 Brugada ECG Pattern in a Patient with Acute Myocarditis. A case report. Is this a coincidental or a consequential association? By Dr. Abdelaziz Jaoudi. The case presentation is one of a 42-year-old male who came to the emergency department who had chest pain with symptoms of common cold and fever. His fever reached 38.3 centigrade, and he had no other cardiovascular risk factors except for occasional cigarette smoking. A CMR study showed positive LGE and evidence of edema in the inferior and lateral left ventricular walls, which favored a diagnosis of acute myocarditis. The authors provide 4 key findings. The first is that acute myocarditis inducing a Brugada ECG pattern as a phenocopy is rare, but a possible differential diagnosis for Brugada syndrome. 2, the pathophysiologic mechanism behind this is unknown, but the authors suggest that myocardial inflammation plays an important role, especially in the first few hours. 3, in this patient case, the type 1 Brugada ECG pattern was transient and had a step-by-step progressive resolution, which could be in favor of the depolarization theory, which is slow conduction due to inflammation preferentially within the right ventricular outflow tract myocardium. 4, the authors posit the question, is it the myocardial inflammation or the fever that was responsible for the Brugada pattern? The next paper is a Fellows Corner paper titled Ventricular Tachycardia, Focal Post-Field Electroporation as Rescue Therapy The authors provide a case of a 71-year-old male with ischemic cardiomyopathy and multiple VT recurrences, ICD shocks, and VT ablations in both 2018. And also in 2019, the latter was endocardial, as was the first. They go on to describe the use of focal PFA ablation. They provide 3 key findings to this case. First, that electroanatomic maps are essential for understanding and clarifying the substrate of each arrhythmia. Second, pulsed field ablation as a novel ablation modality seems to be a safe and efficient approach for recurrent ventricular tachycardia that is refractory to conventional therapies. And third, focal pulsed field ablation with an epicardial approach can penetrate the deep endocardial scar tissue, interrupting the ventricular tachycardia successfully. The next paper is a research letter. It is titled Left Bundle Branch Area Pacing Guided by Intracardiac Echocardiography Imaging by Dr. Fatima Ezzedine and colleagues. The authors aim to assess the procedural workflow and outcomes of ICE-guided left bundle branch area pacing using a venous access obtained through the device pocket for ICE imaging. The key findings are: first, intracardiac echocardiography imaging is a complementary tool to fluoroscopy and electrograms that can guide lead placement in left bundle branch area pacing, particularly in patients with challenging anatomy. Second, delivery of the ICE catheter is feasible and safe through the subclavian venous access in the device pocket. In this non-randomized study, as their final point, there was no difference in the success rate of left bundle branch area pacing or the need for lead repositioning between the ICE and the non-ICE group. Well, thank you so much for listening. This ends the November 2024 podcast. Have a great November, and I will be back on in December.